So I'm going to ask you something that you're not expecting. We thought there was a lot of opportunity in some of the moves to bundled payments.
Yes.
Right? Because a lot of the services that you're mentioning weren't reimbursed in physicians' offices, and you're
Yes.
lucky to have a large practice that really could have supported that. So when you look at, the one or two doc who's, in northern Indiana that may not have that level of service. So we were really encouraged by the per member per month fee that would be paid by the oncology care model. We talked to Anthem about their per member per month to say, look, you need to wrap some of these services into expectations for that per member per member per month fee. So when the OCM is rolled out now as a pilot, and again, I think these are all really great opportunities for us to continue to inform and dialogue on it. The current per member per month fee is only applicable as long as somebody's in active treatment. And as we saw from the data that was presented earlier, we have 70% of patients who aren't in active treatment, but they continue to receive services. So I agree with you that there is an opportunity to create this holistic solution, but how do we think about it along the continuum of cancer care, not just during this narrow window of time when we might be infusing drugs into somebody, right, or doing radiation therapy?
Sure. So a couple comments. First of all, the oncology care model, which does provide a per patient per month fee, as you state, for patients undergoing active therapy, does mandate provision of navigator services. Now, I'll bet you everybody in this room has a different vision of what that actually means, and since there is no definition, your definition is as good as anybody's or is as good as mine. But I think this function that we've identified would be an important component. The second thing is the Institute of Medicine Care Plan does require an estimate of cost of care as one of the 13 elements, and therefore it does put it in front of people if the OCM practices are meeting the requirements of their participation. There's a reason why care is addressed predominantly during the active phase of therapy, and that's because there's tons of published evidence that that's where the dollars are spent. So it's kind of like, where do I look for my lost keys? I look under the spotlight, under the lamplight, because that's where there's light.
Yeah.
So it is overwhelmingly clear that if you want to implement a program that's going to have the greatest potential impact, it's not perfect, then you focus on people undergoing active treatment. Co-insurance for oral cancer drugs has no meaning if you're not on active treatment, right? And so I am sympathetic to the cost of laboratory services, because that's a whole nother discussion. But it's true. But I think that if you look at your total cost, which was incurred during your phases of active therapy, it makes that the cost of that one drug, pales in comparison. Not that it's not impactful on the individual. I think it simply is. You got to start somewhere, and that was where people chose to start.
Okay. I see as an opportunity for us to continue.
I do too.
Yeah.
I think there's. So I've spent a lot of time thinking about how do you take care of people during active therapy. I think, so I've recently written that survivorship, our understanding of survivorship is an abomination. It is. I mean, we don't have any scientific basis for most of what we do. We don't measure performance. I mean, so once we get this active treatment thing fixed up, then we should definitely talk about survivorship.
Great. DJ, what are you thinking after hearing this presentation? You are one of the most highly educated consumers I've ever been around. And I know a lot of times over the last couple of years, you and I have had email exchanges, right? And we've talked about some of the changes and how they might impact patients. So what are your thoughts when you hear the data?
It doesn't surprise me at all. I guess what I'm most surprised about is it's taken this long for everybody in this room to recognize the struggles that that people like me have been going through. I've been dealing with pre-existing conditions since I was 10 years old. And then dealing with the cancer journey since 1987. So I've lived this, and I've been frustrated throughout the years. So I'm really glad that these issues are starting to come out. But boy, we really have a long ways to go, and it's not getting better, it's getting worse. Because I could compare from 87 to 2010, and I actually felt that in 1987, I got better care, even though there were more variables, because I was not seen as a walking dollar sign. I really felt that my doctors had my best care in mind. I don't feel that today. And that's not necessarily true of all doctors. I mean, I still have the same oncologist. 30 years ago, we never talked about costs. We talk about that today.
Jaquetta, when I was listening to the data and I heard about the increased delays for Medicaid populations, is that something that you have experienced? Do patients sort of share a level of anxiety during that waiting period? It just becomes a part of what happens? Talk to us about that.
Yeah, it's certainly something that I've experienced with my clients, and it is 100% something that causes fear and anxiety in my clients. A lot of times when my clients get a cancer diagnosis, it is, I'm gonna die, and I need to do something today. I can't wait till tomorrow. They scheduled this appointment for 2 months from now. Even, the active monitoring or the watch and wait approaches, my clients are not here for that. It scares the crap out of people. So a lot of my clients are Medicaid and Medicare patients, and so I've had to deal with delays due to prior authorizations or denials of claims. My clients don't know how to file appeals. They don't know that that's an option for insurance. Even looking for second opinions in those narrow is not even the word for the network. We have some networks in DC where you either see this oncologist at this practice or one of his friends, or this oncologist at the second practice or one of his colleagues. So it's option A, Washington, D.C., option A, option B. And if you can't travel there, if you can't access it, or for whatever reason, you're stuck. Or you figure out how to change your insurance. So, people not being able to access screening in a timely fashion, not being able to get to an appointment because the cost of transportation in the area is so high, time off of work, all of these things are major issues.
So I'm going to ask you a question. You don't have to be exact in your response, right? And this is intended to be a little prickly,
Okay.
right? Tell us, how far is Whitman Walker from the White House?
Walking distance.
And how many medical centers are within walking distance of Whitman Walker Clinic?
Primary care, we are probably the only one in our neighborhood. We're a community-based health center. But
What about hospital systems?
hospital systems, the closest one would be GW. That's about walking distance as well. Anywhere else, you got to figure it out.
But healthcare, being able to get to a healthcare center, there are a lot of them here in this geography for patients. And patients have essentially two choices
Yeah,
for networks.
that has been the case for more than one of my clients, where they're in an insurance system where they have two options for oncology care.